Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Lack of Effectiveness of Neutropenic Diet and Social Restrictions as Anti-Infective Measures in Children with Acute Myeloid Leukemia, an analysis of study AML BFM 2004 by Tramson et al. My name is Roland Ammann, and I am Associate Professor at the Department of Pediatrics, Inselspital, Bern University Hospital, University of Bern in Bern, Switzerland. My oncologic specialty is pediatric hematology and oncology. In specified high-risk settings in both adult and pediatric oncology, there is established evidence for the prevention of infectious complications by pharmacological measures like prophylactic antibiotics, antifungals, and colony-stimulating factors. The evidence underlying the widespread use of non-pharmacological anti-infective measures, however, is scarce, despite the inherent potential of such restrictions to decrease the patient's and family's quality of life. In their article, Tramson and co-workers combined prospectively collected information from two different sources in order to assess the effectiveness of restrictions on nutrition, social contact, and pets as non-pharmacological anti-infective measures in children treated for acute myeloid leukemia, furthermore abbreviated as AML. The first source was information on infectious complications in pediatric patients with AML who were treated within the multinational AML BFM 2004 trial of the Berlin-Frankfurt-Münster group of pediatric oncology centers. The second source was an international survey on restrictions applied by pediatric oncology centers for patients with AML. For 339 patients treated in 37 German centers, these two sources were matched by center for analysis. Restrictions were assessed by 19 items, which were summarized in 3 restriction scores. Specifically, the nutrition score summarized restrictions on 8 items of the so-called neutropenic diet: raw seafood, raw meat, unpasteurized milk and cheese, uncooked and unpeeled vegetables, salad, nuts, take-out food, and tap water. The social score summarized restrictions on 6 items: indoor public places, outdoor public places, friends visiting at home, daycare, kindergarten, and school. And the PET score summarized restrictions on 5 items: dogs, cats, turtle, hamsters and guinea pigs, and birds at home. 4 types of infectious episodes were assessed as outcomes during the intensive phase of AML chemotherapy, but not during AML maintenance. These were bacteremia, pneumonia, gastroenteritis, and fever without identifiable source. For testing associations between restriction scores and outcomes, adjusted incidence rate ratios and their 95% confidence intervals were calculated using multivariable Poisson regression. 5 potential confounders were used for adjustment. These were sex, age, weight group, AML risk stratification, and prophylactic antibiotics. An incidence rate ratio below 1 indicates that the higher score, reflecting more restrictions, is associated with fewer infectious complications. The results were negative throughout. In the 12 analyses performed, no significant association between any of the 3 restriction scores and any of the 4 outcomes was found. All estimates of adjusted incidence rate ratios were in the range of 0.91 to 1.15. Now, what do these negative results mean for clinical care of our patients? Before discussing this, I will have a look at 3 questions. First, do these negative results simply reflect lack of power because no evidence of associations is not always evidence of no association? My answer, based on the evidence presented in this article, is a clear no. There is no formal post-hoc power analysis, but the large sample size resulted in valid results with narrow 95% confidence intervals. Specifically, the lower bound of the 95% confidence interval of the incidence rate ratio was above 0.90 in 9 of the 12 analyses, and all bounds were above 0.75. A clinically relevant anti-infective effectiveness can thus be excluded for all scores and all outcomes. Second, can these results be transferred to pediatric patients treated with chemotherapy for other malignancies beyond AML? My answer, based on pathophysiological reflections, is yes. Apart from myeloablative chemotherapy requiring hematopoietic stem cell support, AML is treated with the most myelosuppressive chemotherapy known, implying the highest risk for infectious complications. If social, nutritional, and PET restrictions do not reduce the risk of infections in this high-risk situation, they will not reduce this risk in lower-risk situations after less myelosuppressive chemotherapy for other malignancies. In my personal view, specific studies of these questions should be undertaken with methods comparable to or different from the methods reported in this article for AML. But adaptations of clinical care should not wait for the results of such future studies. Third, can these results be transferred to adults treated with chemotherapy for AML or for other malignancies? My answer, based partly on evidence and partly on pathophysiology, is probably yes. A recent meta-analysis did not demonstrate superiority of the neutropenic diet regarding mortality or infection. But there is a clear need for further studies in adults on the effect of social and PET restrictions. In conclusion, this study has relevant implications on clinical care of pediatric patients with cancer. First, there is no evidence supporting the use of a neutropenic diet. The consumption of uncooked vegetables, salad, take-out food, and tap water is safe in countries with standards of hygiene comparable to those of Germany. Second, there is no evidence supporting restrictions on social contacts in routine daily activities like attending nursery or school. Third, there is no evidence supporting restrictions regarding pets, beyond avoiding to have contact with excretions of any pet and contact with reptiles as such. Any restrictions found not to be effective here should be deleted from institutional guidelines and, where applicable, from treatment protocols. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.